Hi, my name is Samuele Cortese. I'm a child and adolescent psychiatrist, currently associate professor at the University of Southampton and honorary consultant child and adolescent psychiatrist with Solent NHS Trust. Today I will present a study on the association between suicidal spectrum behaviors and ADHD. And this is a systematic review and a meta-analysis which is based on a collaboration with colleagues from Paris, in particular Dr. Mathilde Septier and Colleen Stoddard, who really did the bulk of the work, and my colleague Professor Richard Delorme, alongside with another colleague from China. I would like to acknowledge Jianhua Zhang from Yancheng University, China. Before starting my presentation, these are my disclosures of potential conflict of interest. I have a number of collaborations with organizations such as ACAMH, and so I received honoraria for talks mainly on ADHD, and I do not have any other disclosures to declare today. Right, so as a general introduction to this topic, I think it's important to highlight how there is, of course, a large body of evidence on the association between ADHD and other mental health conditions. There is also an increasing body of evidence on the relationship between ADHD and somatic conditions. However, we lack a systematic evidence on the association between ADHD and other relevant outcomes. And one of these is suicide and suicidal spectrum behaviors. So this work really aimed to fill this gap in the literature and to provide a systematic overview and meta-analysis to provide a quantitative data on the relationship between ADHD and suicidal spectrum behaviors, which is, of course, highly relevant in the clinical practice. So before moving to our findings, I would like to provide a general overview on suicidal spectrum behaviors. So as the name suggests, this is really a continuum and includes suicidal ideations as well as suicidal attempts and suicidal plans, and finally completed suicide. And there is a link among these behaviors, as in adolescence, up to 1/3 of those with suicidal ideation have been found to go on to develop suicidal plans. And 33% of these make a suicidal attempt. And eventually it has been reported in the literature, according to this recent study by Nock and colleagues, that 60% of those with a plan versus 20% of those without a plan make a suicidal attempt. And 60% of first attempts have been found to be planned. So in terms of prevalence, clearly these figures highlight the clinical and the public health relevance of this topic. The cross-national lifetime prevalence for suicidal ideation has been found to be around 9%, suicidal plans 9.2%, and suicidal attempt 2.7%. In terms of risk factors, of course, there are a number of risk factors for suicidal behaviors, which are related to several mental health conditions and other situations. However, if we look at the strongest evidence, it turns out that mood disorder is really the main important risk factors, at least in developed countries. While interestingly, in developing countries, the risk factor with the highest, the strongest link with these behaviors has been found to be related to the presence of impulse and control disorders. So this brings us to, of course, the link between ADHD and suicidal spectrum behaviors because of the impulsive component in particular. However, when we look at the literature, findings across studies are quite mixed in terms of significant association between ADHD and suicidal behaviors. And also what is not clear is to which extent comorbid disorders such as mood disorder or substance use disorder and other important psychosocial variables do account for the link between ADHD and suicidal behaviors, or to which extent they act as a mediator or moderator in this link. So we thought that it was important to provide a comprehensive overview of the literature and to use meta-analytic methods to address these questions, to provide the field with hopefully a clear and solid answer to this matter. So we conducted a systematic review and the meta-analysis according to the state-of-art recommendations in the field. We followed the standard guidelines, which are also endorsed by Cochrane and other groups, so the PRISMA guidelines. And importantly, as it is a good practice in this field of research, we pre-registered the protocol in advance so that the outcomes and the aims and the methods were clear from the beginning to avoid bias in reporting results later on. So in terms of search strategy to retrieve the evidence, to retrieve the studies, we look at a comprehensive set of electronic databases, including the most common ones, which are PubMed, a set of Ovid databases, including PsycInfo, Ovid Medline, and Embase Classic, and also all the set of databases of Web of Knowledge. So we think that this strategy was quite comprehensive. However, as it is common practice, we also checked and hand searched all the references of relevant reviews, previous reviews in the field. And importantly, and this was quite a time-consuming process, but I think something that added value to and rigor to our study was that we contacted the corresponding authors of the studies to retrieve additional information and to clarify aspects that were not clear from the published paper. Right, so this is just an example of search terms and search syntax that we use for PubMed. As you can see, a broad set of terms to include hopefully all and to retrieve all available studies. And the search was adapted for other databases. So in terms of the type of studies that we included in our systematic review, we basically looked at all observational empirical studies that reported the data on the association between ADHD and suicidal spectrum behaviors, or also those studies that without directly reporting this data provided data that could be useful for us in terms of calculating the association. We did not include, of course, case reports, and also we excluded, of course, randomized controlled trials on ADHD because usually suicide, fortunately, is quite a rare event in trials, and so it would not have been possible to capture the prevalence from this type of studies. And we did include the longitudinal studies, but of course for these ones we just extracted data at the baseline. Right, so in terms of the types of participants, we included studies on children, adolescents or adults with ADHD defined according to standardized criteria as per DSM or ICD, or also studies where ADHD was defined as the presence of a number of symptoms and symptom severity above a cutoff. Of course, this is a less rigorous definition of ADHD, but it is something that is quite often implemented in epidemiological studies. So in order to address the possible bias of including these studies, we also plan a sensitivity analysis where we removed studies where ADHD was not defined according to standardized criteria. And in terms of the outcomes we were interested in, of course, the primary outcome was a statistical measure expressing the association between ADHD and suicidal behaviors, and this is usually the odor ratio, which is used commonly in studies addressing association between variables. Is not clinically straightforward, but is the most commonly reported measure. A secondary outcome, which we think actually is very important, was the odor ratio from each study adjusted for a number of confounding factors. So when you run a study on the association between two variables, you can just assess the crude association, but you can also adjust statistically to assess the impact of possible confounding factors. So the aim of the secondary analysis on the secondary outcome was really to check to which extent the results from the primary analysis were solid after controlling for possible confounding factors. Needless to say, each study controlled for different confounding factors, so we don't have a common set of confounding factors that have been adjusted for consistently across the studies. So this is the plan of the statistical analysis. We use basically quite standard methods in the field, random effect models, the method suggested by the Sirmonian and Laird. Basically it is a standard method in the field. We also did subgroup analysis and meta-regression to assess the impact of important variables, and I will highlight this during the presentation of the results. We assess importantly something that should be done every time you run a meta-analysis, so the heterogeneity, so to which extent the studies that we pooled were homogeneous or not, and also the publication bias with the Eggers test. This is very important because if there is evidence that we pool studies that are impacted by possible publication bias, the conclusions should be taken with caution. And so comprehensive meta-analysis was the software that we use to run the analysis. And finally, this is not really part of the statistical analysis per se, but is an important component of a systematic review and meta-analysis. We assess the quality of the studies. This is important because it's really fundamental to appreciate to which extent the studies that we included were of good quality or not. And we use a tool which is commonly used for epidemiological studies, which is called Newcastle-Ottawa scale, which addresses a number of aspects related to the quality of the study, mainly in terms of the comparison between individuals with that particular disorder and individuals without the disorder. Right, so this is what is called usually the PRISMA flow chart, and is a graphic representation to show really the selection process in terms of screening of studies. So after we considered and we screened across all the databases, we had almost 3,000 references to screen, and then eventually, after discarding the non-relevant references and studies, we ended up with 57 original studies that were pooled in our meta-analysis. And this gave us a total of 90,000 participants with ADHD across all these studies, and more than 200,000 individuals without ADHD. And so, of course, this gave us a relevant statistical power to address the questions we wanted to answer. Right, so I will present now in a series of slides the results of the main analysis. So for those who are not familiar with this way of representing the results, this is what is called a forest plot. In this case, this is the analysis on the unadjusted or crude odor ratio for the outcome suicidal attempts. For each analysis, we actually address each individual suicidal behavior. So this graph relates to the relationship between ADHD and suicidal attempts. Each study is represented on here, and each study has a particular odor ratio, which is represented on the right side as an average effect with its confidence interval. And when the confidence interval crosses the line of 1, in this case, it means that that particular study suggests that there is not a significant association between ADHD and suicidal behaviors. When all the confidence interval is higher than 1, such as in this case, for instance, well, this means that the study suggests that definitely there is an increased risk of suicidal behaviors in individuals with ADHD. And when it is on that side, it means that actually there is a decreased risk of suicide. So you can see just from examining each confidence interval from each study that there is a lot of variability in terms of results across studies. And so this was really the purpose of the meta-analysis, to combine them in order to have higher statistical power and to see if there is a direction in terms of a possible effect. And actually what we found is that yes, there is a significant association, which means that there is an increased risk of suicidal attempts in this case in ADHD, because the final effect, which is derived from the meta-analysis, is represented at the bottom here in red, and as you can see, the confidence interval is above 1, which clearly states that there is a statistical significant association between increased risk of ADHD and suicidal attempts. This was the case also for when we considered the odor ratio from each study, unadjusted odor ratio for suicidal ideation, and also for with a larger effect for complete suicide. Now, these are important values, but they need to be taken into the context of additional data. So first of all, this is another table which summarizes all the results. So first of all, we need to consider I-square, which, as I mentioned, is an index of heterogeneity across studies. And in this table is represented here. So as you can see, in all the analysis we ran, the I-square was higher than 50%. This means that we cannot be completely confident in these results because the studies were quite heterogeneous. So when you pull, of course, different studies, you need to pay attention in interpreting the results. This does not mean that our results are not valid, but it simply means that the final estimate that we derived cannot fully represent all the heterogeneity across studies. Then what I presented previously, as you may remember, are the results for the unadjusted odor ratio. For each analysis, as you may remember, we also calculated as a secondary outcome the pool adjusted odds ratio, adjusted for a number of confounders. And we think that this is more, in a way, is more reliable measure of the association because it takes into account possible confounding factors. So one may think, well, there is an association between ADHD and suicidal behaviors, which is significant, but it may be accounted for by another factor which is related both to ADHD and suicide. For example, I don't know, low socioeconomic status. So after taking into account socioeconomic status, is this association still valid? So this is why we also pull the adjusted odds ratio from each study. And you can see this on the left side in green. So for each outcome, suicidal attempts, suicidal ideation, suicide, unspecified behaviors, and suicidal plans, we calculated where available also the pool adjusted odds ratio. So actually this was available just for suicidal attempts and suicidal ideation. Unfortunately for these other outcomes here, adjusted odds ratios were not available. And what we can see here is that even when we consider adjusted odds ratio, the association is still significant. A quick way to look at this is to look at the p-values here, and when they are lower than 0.05, this means that there is a significant association. So to summarize, when we consider both unadjusted and adjusted odds ratio, when we pull them from each study, there is a significant increased risk of suicidal attempts and suicidal ideation and suicide and suicidal plans in individuals with ADHD. The only outcome for which we did not find a significant association, and I have highlighted this in red here, is what the studies coded as unspecified suicidal behavior. However, this is quite a vague term, so we should consider this with caution. Right, so this table refers to all the studies pulled together, but we were also interested in performing subgroup analysis, just retaining some type of studies to see if the association was still significant. So the risk was still increased. And for instance, we wanted to know, is the risk increase in population-based or epidemiological studies as well as in clinical studies. Actually, what we found was a quite interesting pattern. So when it comes to unadjusted odds ratio, both for clinical and epidemiological studies splitted, we did find a significant association. So once again, the way to know if the association was significant is to look at the p-value here. However, when we consider the adjusted odds ratio, both for clinical and epidemiological studies, the association was significant just for the epidemiological study, not for the clinical ones. And likewise, as you can see here, when we consider the unspecified suicidal behaviors, the association was not significant for clinical, but it was for epidemiological. So it looks like the setting of the study is a factor that may influence the association. We do not know really the exact reason for that. We suspect is related to the severity of the clinical situation, which of course is more evident in a clinical setting. Right, so in another subgroup analysis, we also wanted to look at the association in terms of current versus lifetime prevalence of suicidal behavior. So, of course, when we assess a variable in a study, we can look at the prevalence of this variable in a specific time point or across life, basically. So current versus lifetime. And basically this subgroup meta-analysis told us that basically results were quite solid and didn't change according to the temporal type of the variable. Then, of course, we also wanted to look if other characteristics of the study design had an impact. So we considering this as a group analysis, we split the cross-sectional versus retrospective or prospective studies. Also because this is relevant in terms of the reporting of the outcome. In a retrospective study, this outcome is reported retrospectively, and so we may wonder to which extent it is accurate. However, it looked like this variable did not have a significant effect on the results. So the results were still there when we considered the type of design. Finally, as I mentioned, we conducted a specific analysis which is called meta-regression, and this is meant to assess the impact of specific variables on the results. So we may wonder, is this association the same regardless of the age of the patient? Is it the same regarding of the year the study was published? Or is the same across continents? Or is it impacted by the quality of the study? Well, actually, we did find that none of these variables had a significant impact on the association, which means that the association between ADHD and suicidal behaviors, most of them, was still there regardless of the age, the gender, the year of study publication, the study continent, and the study quality. And in terms actually of the study quality, as I mentioned previously, we did use a rigorous method to assess this. And overall, it turned out that the quality of the study was in general quite good in most of the parameters that we considered. So to rate the quality of the study, we can do this on a scale from 0 to 4, and in many parameters were 2.5 or 3 or higher than this value. So in terms of the discussion of this finding, I think that overall we believe that our study is relevant because it extends in a way the conclusion of previous studies that were only non-systematic reviews or individual studies, and it provides us with numbers, with figures that we can use in our clinical practice and when we discuss, of course, with patients. Previous studies did not provide us with a clear answer on which variables could influence the relationship between ADHD and suicidal behaviors. And I hope I made it clear that we did perform an extensive set of analysis to assess the impact of these variables. And also, we need to point out, of course, that we cannot be fully confident in our results because, as I mentioned, each study adjusted for different variables. So ideally, we would like to see all studies controlling for the same confounding factors. This will provide us with a more solid evidence. But as it always happens, a meta-analysis is never the final answer to a question. Oftentimes, it points us to the right direction for future studies. So we think that our meta-analysis should also inform future research in the field. In terms of the limitation, of course, of our study, I like to point out that, of course, this is a meta-analysis assessing the so-called cross-sectional association. So it does not tell us anything in terms of the cause-effect relationship and the temporality. So we just established that if you look at individuals with ADHD and if you compare them to individuals without ADHD, those with ADHD have an increased risk of suicide, but we don't know what are the causes for that, and we don't know the temporal link. It is possible, there are possible, a number of possible explanations. I will highlight here, in the interest of time, just two of these. The first is that ADHD per se contributes, so causally is a risk factor, is a causal factor to suicidal behaviors via the impulsive component, and more generally via the deficits in all the executive functions. However, it is also possible that both ADHD and suicidal spectrum behaviors are underpinned by common neurobiological and psychopathological mechanisms. For instance, there is evidence of a shared genetic vulnerability between suicidal spectrum behaviors and impulsive behaviors, and you can see here some of the genes that have been implicated. Of course, an important factor that we should consider when we try to explain the association between ADHD and suicidal behaviors is the possible role of the pharmacological treatment, the medication for ADHD. And this is clearly important, especially for clinicians, for prescribers. Is extremely important question to address. Now, the problem is that in general, this is not easy to understand. If you consider, for example, if you compare, you run an epidemiological study, a population-based study, and you compare the rates of suicidal behaviors in a group treated with ADHD medication and in another group of individuals not treated with ADHD medication, and you find that the risk of suicidal behavior is higher in the group treated with the medication, you cannot conclude that this is due to the medication, because the two groups may be different. We may think, for example, that the treated group is more severe, so per se they may present with more psychopathology and more risk. So there is, however, a clever type of design, study design, which may be informative in this regard, which is called the self-control or within case design, whereby basically each individual is considered when they are on and off medication. And you can compare the prevalence of suicidal behaviors when they are on medication and off medication. So you control for a series, you adjust naturally for a series of confounding factors. The only aspect that this design cannot control is related to those factors that changes over time. But there are some also statistical approach to partially control for this. So we found just two studies that use this self-control methodology. And the first one is this study that was published by colleagues from Sweden in the BMJ, and actually they found that there is no significant association between use of psychostimulants for ADHD and increased risk of suicide. If anything, as suggested by the odds ratio, which was below 1, actually, if anything, stimulants seem to have rather a protective factor, while in terms of non-stimulants, there was no really association at all, because the confidence interval of the hazard risk was crossing 1. So basically, it means that there is no protective and there is no an increased risk of suicidal behavior with non-stimulants. The second study provided a slightly different results, a very interesting one. So this was a study from Hong Kong, published in JAMA Psychiatry, and what they found was that when they look at the risk of suicidal behaviors in those treated with methylphenidate, actually in the period 90 days before starting the treatment, the risk was higher than 1, clearly, so it was significant. And it stayed higher than 1, so it remains significant, even during the first 90 days following the initial prescription of the medication. However, then the risk became not significant later on. As you can see here, the confidence interval crosses the line of 1. So this may suggest, there are of course many explanations for this, but what the authors seem to suggest is that the period before and immediately during the initial treatment is very critical period, and is when these patients are in distress and they go and see their psychiatrist or prescriber and to seek a prescription. However, once the treatment starts being effective, the distress and the risk may decrease. Of course, we need additional evidence, but so far it will be quite tricky to argue based on available evidence that medications for ADHD per se have a causal role in increasing the risk of suicidal behaviors. Right, other limitations that we should point out in our studies, as I mentioned, I-square, which is a measure of heterogeneity, was quite high, which means that our estimate, our figures, do not capture the variability across studies. And also, I mentioned previously that in general the study quality was quite good. However, there were some items of the scale that we used to assess the study quality, which indicated some issues in terms of possible bias in the methodology of the studies. So moving to the possible clinical implications of this study, I do think that it is important because it suggests that we should systematically screen for suicidal spectrum behaviors in patients with ADHD. Of course, at the first assessment, also the follow-up. And this, I think, is particularly relevant because when we look at available rating scales and questionnaires on ADHD, they do not in general include specific items on this. So this may be missed if we perform a quite quick and standard assessment of ADHD. While of course, given the importance of this screening for these aspects seems extremely important. I think that was all in terms of my presentation, so I thank you for your attention.